for long-term methotrexate use, tamoxifen, hemochromatosis, autoimmune hepatitis, celiac disease, Wilson's disease, beta-lipoproteinemia, lipoatrophy, and sometimes microvascular steatosis can also occur in the race disease. Medications like valproate, ARTs, acute fatty liver in the pregnancy, HELP syndrome, and many inborn errors of the metabolism are also associated with the deposition of the microvascular steatosis. Asian Indians have low insulin sensitivity compared to the Caucasian counterpart. It is well known fact. In India, the prevalence of the insulin resistance is 35% even in the young age. So the deposition of the fat starts with the young age. Many times we always remain in this confusion that diabetes is starting on the day when we are first diagnosed with the hyperglycemia. Actually, we are wrong. Diabetes is starting on a day 15 years before when we are diagnosing and we are getting our hyperglycemia for the first time. 15 years before the endothelial dysfunction process starts taking place, and after that we start having the rising insulin resistance that goes up with our physical inactivity, and obviously the dietary habits also have some say over that, but it increases gradually with the deposition of the fat, and that is the reason after generations and generations the occurrence of the diabetes is going back in the age. Earlier it was in the 60 years above, later it has been on the 40 years above, and now we can see that type 2 diabetes in the 20 years and above. So insulin resistance is one of the root cause factor, and if we need to diagnose the 5% steatosis in hepatocytes should be confirmed by the biopsy or imaging methods. Insulin resistance should be confirmed, and there should not be any secondary causes, what I have already enumerated in my previous slide, and alcohol consumption should not be more than 30 gram in a day for men and 20 gram in a day for women. If it is like that, then we can say that probably this is the patient of the NAFLD. So if we talk about its prevalence, it is a growing public health problem reaching to the epidemic proportion and is considered as the most common cause of the chronic liver disease nowadays, and in future we shall be seeing a lot of cases of the chronic liver disease which are arising out of this NAFLD caused by the insulin resistance, which may be involved with the diabetes, obesity, diabetes together. The prevalence of the NAFLD is 31% by MR spectroscopy, 12.2% by histology, of which 5% are associated with the inflammation that is called as non-alcoholic steatohepatitis. The prevalence of the NAFLD in diabetic individual is 59.67%, means almost 60% diabetic patients are developing the NAFLD, and it has been seen that biopsy proven NASH in asymptomatic type 2 diabetes patient is going to this level, and we can see that even 20% of them are having normal liver function test. So actually the liver function test or liver enzymes are not the true reflector of the NAFLD. 20% of them keeps on normal. So if we talk about the comorbidities with the NAFLD, so obviously the metabolic conditions are giving rise to that, which includes, as I already said, type 2 diabetes, obesity, dyslipidemia, and of course hypertension. Hypertension is also one of the important diseases which is associated with the high insulin resistance. So whenever we are coming across with the hypertension 140/90 or more than that, this may be one of the important factor which is giving rise to the fat deposition in the liver. But the most important thing which is causing NAFLD in our youngsters, that is the physical inactivity. Physical inactivity, high calorie diet, sweetened beverage, high fructose intake, and obstructive sleep apnea, which is growing with the weight gain and obesity. Obviously, the reflection of the same high insulin resistance we can see in our young girls in the form of the polycystic ovarian syndrome. So overall prevalence NAFLD in India up to 32%, NAFLD in obesity is almost 80%, and type 2 diabetes 70 to 80%, and 50% are progressed to advanced fibrosis. So this is the scenario of the pathophysiology we start. As I already said that we are starting the diabetes on the day when we know that hyperglycemia has first detected. But even 10 years or 15 years before the process of that hyperglycemia and pathophysiology start taking, which from with the endothelial dysfunction, and at the same time we start getting the rising of the insulin resistance, which starts developing the fat deposition even in the lean state of the diabetes when a person is in the non-hyperglycemic state. And when it comes to the hyperglycemic state and beta cell dysfunction is going rising up to the highest level, where you can see that insulin resistance at the highest of its level, but the insulin secretion at the lowest of its level, and we can see the highest amount of the fat deposition there. Let's talk about the pathophysiology. कैसे होता है, कहाँ से आता है, ये सब चीजें क्यों डेवलप होती है? If we talk about the fat which is coming to the liver, is coming from the three important sources. हम लोगों में से बहुत सारे लोग ऐसा सोचते हैं कि ये जो हम खाना खा रहे हैं फैट उसमें से आ रहा है, but actually it is not the food derived that much. It is contributing up to certain extent, but the maximum is coming through the free fatty acids which is in the circulation. And free fatty acids which is in the circulation, it is coming because of the insulin resistance. So it is coming, insulin resistance is coming because of our physical inactivity. So if we increase our physical inactivity, we can stop this or reduce the amount of this free fatty acid which is coming. I can tell you it's around 56% of the total fat which is going to be deposited in the liver is contributed by the free fatty acid. And 26% is contributed by the de novo lipogenesis. What is the de novo lipogenesis? De novo lipogenesis is that what we take in the form of the carbohydrate, but we do not spend. We take lot of energy in the form of the carbohydrate, but we do not spend in the form of the energy, and that carbohydrate gets converted into the fat and deposited in the liver. That is called as de novo lipogenesis. That's why we always say if you will reduce the carbohydrate content in the diet or in the food, probably you may be able to control your diabetes, insulin resistance, and FLD, and all diseases which are associated with the insulin resistance. So as I could say, and I could make you understood well, that this free fatty acids is the largest contributor of the fat deposition in the liver. And once this fat deposition comes in the liver, as it is already associated with the continuously increasing insulin resistance, which is not only giving rise to the alpha cell increased secretion of the glucagon, beta cell decreased secretion of the insulin, at the same time more of the amino acids are released, and lot of environmental genetic factors are also responsible, what has been very well explained by my previous speaker Dr. Arun Kedia in his one of the slides. And ultimately not only it leads to the obesity, not only it leads to the liver dysfunction. I am not much worried about the cirrhosis which will be developing after 10 years or 20 years. I am more worried about the conversion of this fat into the VLDL, triglyceride, and reduction in the level of the HDL, which is the protective cholesterol, and that will make my youngsters into the cardiovascular disease, make my youngsters to get the heart attack in their early life.